Many of you are probably wondering, what is health policy? Because that's something I've talked about, and it's obviously a component of all that we're doing. And one of the components that underlies all of health policy is healthcare and public health and bioethics. But underlying all of that is sort of like there are limitations that things that individuals can do, but they really can't be a harm to themselves or others. And by others, we mean the bigger community. So the Constitution gives lots of people individual rights. However, those individual rights cannot necessarily impact the bigger community in a negative way. So you have the right to do certain things, but not if they impact others in a negative way. And that's sort of where public health kind of comes into the policy making decision. And that could be on the local level, the state level, the federal level, and on the international level too. So public health doesn't just start here. It's everywhere. There are issues that we have to contend with all over. And one of the reasons why these issues are getting more prominent is because diseases can travel anywhere within 12 hours. So somebody can have a disease like Ebola fly here, and then it's here. And that is a contagious disease, we'll talk about in the next couple of videos. So a lot of new diseases and things that health risks, don't have sort of this containment of that's over there, not here. And you can get them over here very quickly. We see with global warming that Zika and diseases that affect tropical places, they need a certain temperature to be something that's passed on. Well, that moves up because now suddenly Puerto Rico is warmer and Florida, and then suddenly it's all the way up to, here because it's warmer than ever before. So this sort of non-containment means that we're going to see these issues of health, public health specifically, of the rights of the individual versus the general good, or the rights of society not to be harmed by the rights of the individual, are going to come into some clashes and some contacts that are going to be a little messy. We also see that part of this is because public health and health policies are made by lots of different people. So they could be made by private groups, they could be made by trade groups, they can be made by government organizations. Each government can have their own policy. So when SARS, which was a very communicable disease, was going around the globe, China, before you get off a plane there, would take your temperature, and if you had a temperature, you couldn't get off. In places such as Canada, which you think of as so progressive, if you came in, they would put you in isolation. They wouldn't let people in buildings if they had a fever, and they would put them in isolation in a hospital or somewhere else, even if they felt fine, because they might have it. So they contained it. It didn't go very far. But those are very restrictive policies. And you're always going to hear some uproar, especially in the United States, about how much we can or can't do to protect the public from a health risk. Every single thing that we do in health policy is really talking about the role of the government versus the role of the individuals. And I can't emphasize that enough, even though I've said it about 5 times already, because that really talks and speaks to another concept that we have in public health, which is sort of the social justice versus the market justice. And one of the differences in public health is that we're looking more like we want more social justice versus market justice. Social justice is talking about the rights of the society and that everyone should have the right to health. Market justice says your access to health and health care and health intervention is based on how much you can pay for it and how many resources you have to pay for it. So it's a very big, and you're going to see this conversation about market versus social justice in almost all of healthcare, especially in America where we don't have universal access to healthcare. And part of what you're seeing is that debate going on. There are people who say, well, you have to have a job, then you can buy whatever healthcare you want. You have to have these resources. It's not your right to have healthcare. Then 98% of the rest of the world says that it's a human right to have access to healthcare. Again, for some of the reasons we talked about in the very, very beginning of class, that if you don't have your health, you really can't participate in society in other ways. But whose responsibility is that for healthcare? Is it the government's responsibility to keep you healthy, to make sure you have access to individuals that can continue this happiness, or is it whatever you can provide for in a marketplace and buy? And that is an ongoing conversation in policy in America. It's one of the reasons why the Affordable Care Act is so contentious. It's one of the reasons why people do or don't do things like vaccines. Is it the right of the individual to do whatever they want? And if they don't think that they should have them, then it's fine. What happens is that when we have herd immunity, which means we have less than 95% of people immunized, then people can easily catch the disease. And if I coughed and I have measles, then all of you that were in the room with me, 90% of you, if you didn't have immunizations, would have caught that disease. It's that contagious. It's one of the most contagious diseases. With immunizations, people don't catch it. Some people are too young to get it, so if you had an infant and they hadn't had the immunization and I coughed, they could have gotten it. It would have been tragic for them. Older people who don't have immunizations might have also got it, and it could have had worse outcomes for them because they have lower immunities. They have other comorbidities, other diseases that impact their ability to fight off diseases. So one of the ideas behind making sure that the 95% herd immunity exists is to protect the bigger population, people who can't, because of their age, get immunizations. What we've seen with that, though, is that we saw people say, well, I don't have to, I want to opt out of the system. And those people are not the people you think they are. One of the highest percentage of people not immunized before we passed state laws to remedy that weren't living in places you think they are. They were in Oak Park. And when we see people who aren't immunized in places like California, it is in very rich, predominantly white enclaves of where they live. They get options out. They don't think it's this, they don't think it's that, even though the science has shown that it doesn't cause the things that they think it does, and it was just a recent study that again proved it. But they think that they can opt out as their rights of individuals. However, states are now saying, no, for the health and safety of everybody, you can't opt out. We need to make sure that these diseases don't come back. People who are a lot older than us can remember when people got polio and they were paralyzed or they died. Polio is something you can get exposed to, not be paralyzed, and it comes back the rest of your life. We don't see that a lot, and a lot of people don't see it, so we've been too successful, so they don't think they're going to be impacted, but you will be. So we've been successful, and that sort of impacted how we can get everybody to think they're really at risk. Remember, we talked about that in the previous couple lectures about how you have to make sure people understand their perception of risk. One of the reasons people think that they don't need to get immunized is because nobody gets it. Partially because everybody gets immunized, so it's a circular thing. So one of the interventions, and I want to sort of stress this intervention and sort of pull together everything we're talking about, is we don't fine them. That would be a policy intervention, but we also make it on the state level. We've worked to make it harder for those people to get exemptions because we don't want them exposed to other people. If a child is exposed to a child that does have the disease and hasn't had immunization, and that child has a younger sibling they go home to, then they've been a carrier for that. So we're impacting people who have no choice about being exposed to it. We want to make sure that doesn't happen. It's something that means people could be hospitalized, and these are usually children or old people, so it's a very big impact. Again, we talked about what's the impact. It's immediate for the most part, within a couple months or a month. That's bad. All of these things are very contagious. Some of the impacts are lifelong. It's not just sort of a one-off, you're sick and then you're better. It impacts your immune system for a long, long time, or has negative physical impacts. So states have then said you can't have this exemption. But we've also looked at the individual level, right? So one of the strongest ways to get parents who don't want to immunize their children to do it is not to fine them and not for me to lecture them. But if they came to my practice and I'm a pediatrician, I could sort of listen to what they say, and I could tell them ways in which we could immunize their child in a different way, do things a different way, explain it to them one-on-one, and we've seen that that works the most. It isn't the internet. It's that one-to-one communication with a healthcare professional, be it a nurse practitioner, PA, community health worker. That's another thing. We could send a community health worker to your house to sort of explain it to you and understand your fears. And that works, that intervention works the best with those people who are trying to opt out. So we've sort of shown how we've tried to change policy, and we have. California now has one of the most restricted, you can't opt out laws. Okay, that's at a state level and impacts all the local levels. It's stronger than the one we have in the United States as a whole. Some places have very strong ones, such as Louisiana, who has the highest immunization rate of all. But they have a very strong federal law, but they've also helped people overcome it with sending out community health workers. Places who want to improve their immunization in California have then re-educated healthcare providers who come in contact with these parents and these children to sort of engage in a conversation, because we've seen that that works the best. When we talk about globally, a lot of people don't want to get immunizations because they think that we're either trying to kill them, or they're hard to reach places, or they don't understand the science behind it, or they don't trust healthcare professionals. Again, that's where a community health worker could come in. They're usually women who will go, and they can come into the households of places. They will talk about what the impact of this is. They will talk about how it will impact the rest of their family. Again, their intervention and their conversation is based on what the experience and what works with that population within that cultural domain. And it's been most impactful. We've had places who've almost got 100% immunization rate. So there are places overseas that have a higher immunization rate than the state of Illinois, with Oak Park being one of the highest non-immunization rates, because of how we have come up with public health models, interventions, and we've measured their impactfulness, and we've tried to duplicate them. Again, based on where they're going, who they're going to, and we've had the community involved. We then also passed global legislation. We provided globally so that people can afford these immunizations, and then adapted that intervention to the local level. So health policy is just as complex as public health. It has to talk about the local community. It has to look at federal, state, local level laws, but it also has to look at ways to sort of do interventions within specific communities. Public health officials sort of help test those models, help implement those models, help train those models. Again, we're doing that technical assistance, making sure that people who can't afford the immunizations have access to them, seeing what works the best, helping people do those best practices, and then measuring how impactful it is. But we're also working very hard to make sure that the health policies that are changed and impacted and passed through legislatures, local, state, federal, globally, are also understanding of things like fairness and general concepts that we hold very, very dear. We want to make sure that we advocate and work for the empowerment of disenfranchised communities. We want to make sure that everybody has basic access to basic resources. It's not just the rich that get the shots, it's everybody who gets it. It's not just the rich who get community workers that come and talk to them, it's everyone who needs it. We also look to enforce the needs of each program being implemented in a way that's reactive and understanding of their community. It's not one size fits all. We also look at ways to look at the causes of disease and try to impact those causes, whether it be environmental or social or access to things like we talked about a couple lectures ago, like food and health and education and work and all those kinds of things that impact health outcomes. We are looking at the whole model, not just a part, and trying to sort of put our fingers in that little part and make that better. We also look at giving communities information so that they can be involved in the process. They can measure the outcomes in ways that are impactful to them, not just numbers, and that they can be part of doing the intervention. It's not, again, that top-down or that just bottom-up. It's working in partnership with them. They have as much to tell us as we do to tell them. We can tell them these great policies, but if they say, no, that's not going to work based on our culture, then it's up to us to help them think of a way so we can get to where we want to get to as far as positive health outcomes. It's up to us to make sure that we understand that we will protect people's health information, that we will not expose who is or isn't immunized, those kinds of things, in order to get a policy passed. We keep all of that in mind when we're doing health policy and when we're doing health interventions, and we're looking at everybody, not just the people who are normally measured, to make sure that everybody has access to improving their health outcomes.